So one of the drugs that I think is so useful for dermatologists at this point that we're not really using the way we should is metformin. And so metformin is a drug that's been around forever. It is incredibly safe. It's a drug that is generally used for treating type 2 diabetes. And there's this perception that it's risky or it could cause hypoglycemia or metabolic acidosis. It is an incredibly safe drug. And really there are several places that we can use it. So first, acne. So one of the things that we're really trying to do in dermatology is get away from using oral antibiotics in acne. We have a reasonably good study showing that metformin is just as effective as antibiotics in inflammatory acne. So it's one of the things that can allow us to get away from antibiotics. Number two, central centrifugal cicatricial alopecia. So this scarring alopecia that we particularly see women of color get on the scalp. This really is my first line go-to. We can use it orally or topically, so we have good data that compounded 10% metformin solution is very good for CCCA. And then the third place that I think we get the most use out of it is in hidradenitis suppurativa. And again, we have a couple of good studies looking at it for hidradenitis suppurativa. There I tend to use it more as add-on therapy to other things, like a highly effective biologic or as a follow-up therapy for somebody who is on antibiotics but then relapses when they come off the antibiotics. But those are the three biggest uses for metformin in dermatology, but they're all three things that come up pretty frequently. So pimozide for delusions of parasitosis is such a fascinating topic. And the reason, when patients take it, it is dramatically effective. Way more effective than any other drug for any other delusion. And that is a very interesting thing because it really makes me question if delusions of parasitosis is really just a delusion or if there's more to it than that. And so there are the mechanism that we all kind of assume pimozide is working through is that it's an antipsychotic and it is treating the sort of psychosis component of having a delusion. The problem with that is we have data that shows that pimozide doesn't work for any other delusions. And so it really calls it into question. And whenever we look deeper, we find that pimozide also has good data that it's effective as an antibiotic against intracellular bacteria. And we know that intracellular bacteria can cause issues with cutaneous nerve function. It also has activity against toxoplasmosis. And what is fascinating about toxoplasmosis, two of the symptoms of toxoplasmosis is a parasite that about 12% of the population carries in their brain. Two of the symptoms are tactile hallucinations, so the feelings of something crawling on or in your skin, and delusions. And so I'm a believer that it is possible that many of our delusions of parasitosis patients actually do have a parasitic infection. It's just that it's this toxoplasmosis, which is a parasite that lives in our brain, rather than a parasite that lives in our skin. So JAK inhibitors have been an absolute game changer in alopecia areata. They're the first treatments we've ever had that really work and have good data. The problem is people with the worst alopecia areata have a low response rate. So probably a third, maybe a half of people will eventually respond to a JAK inhibitor if they have alopecia totalis or universalis. The things that we can do to make it work better. Whenever I first start somebody on a JAK inhibitor, I really encourage them to use clobetasol under occlusion. So for the first few months, basically put clobetasol ointment on your head, put a swim cap over it, try and keep that on for a couple of hours every day. You can do it in the evenings, you can do it before you go to bed. You can sleep with it on if you can tolerate it. That is to get the hair started growing. Now the problem historically was, as the hair started to grow, the clobetasol can't get down to the scalp, so then it falls back out. But now if we start the clobetasol and start them on a JAK inhibitor together, the clobetasol jump starts the regrowth process and then the JAK inhibitor is able to maintain it. The second thing that we can do if we've got somebody on a JAK inhibitor for about 6 months, and they haven't really responded, we now have good evidence that adding some systemic corticosteroid on can help. And the two things that we have the best evidence for are dexamethasone pulses, and so that's 3 to 6 milligrams of dexamethasone 2 days a week, and we would do that for 3 to 6 months, or intramuscular triamcinolone. We give people 40 milligrams once a month, and again, we can do that for 3 to 6 months. And the idea is once the steroid combined with the JAK stimulates the regrowth to start, we can then stop the steroid, maintain them on the JAK, and they are highly likely to maintain that regrowth. So burning mouth syndrome becomes such a difficult thing to deal with. Luckily, we're starting to get some studies that give us some ways to help these patients who are suffering miserably. And I actually use these same treatments in what I call burning lip syndrome. So we see more and more patients who have normal looking lips, but they're getting burning and are constantly putting on various lip balms. The three things that we have reasonably good evidence for at this point, number one, there's a probiotic, so a live bacteria, but it is a probiotic for your mouth, not for your intestines. It's called Biogaia, Biogaia. You can get it on Amazon. It's not ridiculously expensive. That's got fairly good data. Number two, melatonin. And so that one was really surprising to me. You can do 1 to 3 milligrams of melatonin QHS, has pretty good data that it works. And then the third thing, gabapentin liquid. So gabapentin comes in a syrup for oral use for people who can't swallow pills. You can use that as almost, or not even as almost, you can use it as a swish and spit. And so people put the liquid in their mouth, try and hold it in there for 5 to 10 minutes. If they're having a lot of problems with their lips, kind of do that to get good contact of it to their lips. And those are three things that are really outside the box approaches for burning mouth and burning lips, which are really difficult problems to deal with. There have been some incredibly interesting new things, especially around atopic dermatitis. And really the big, what I would call the most important journal articles about atopic dermatitis have been, number one, that we are terrible at diagnosing it. So as dermatology providers, we misdiagnose 2 out of 3 people who have atopic dermatitis. Instead of calling it atopic dermatitis, we're diagnosing it as dermatitis unspecified. That needs to stop. Number two, why are we misdiagnosing it? We're misdiagnosing it because we're using the wrong criteria. So there are criteria from the 1980s called the Hanifin and Reka criteria. We shouldn't be using those anymore. We should be using the American Academy of Dermatology criteria, which are much better criteria for adult atopic dermatitis. Why are the AAD criteria so much better? The AAD criteria are better because the data has now proven that the Hanifin and Reka criteria from the 80s are just wrong. So they are very good for childhood onset atopic dermatitis, totally wrong for adult onset atopic dermatitis. Adult onset atopic dermatitis, which is the majority, the substantial majority of atopic derm is adult onset. It is not flexural. That is the least common area on the body to be involved, and they don't have atopic comorbidities. So why does it look so different, right? Why does adult onset look so different than childhood onset? It's because we now know that adult onset disease is acquired disease, childhood onset disease is genetic disease. And so they both are ways of leading to skin damage and having inadequate barrier function so that your skin is just susceptible to the environment in general. But in childhood onset atopic derm, it is genetically your skin doesn't work. In adult onset atopic derm, it is that your skin has been damaged. And then finally, okay, in adult onset atopic dermatitis, what is your skin being damaged by? It is being damaged in particular by a chemical called toluene diisocyanate, which is a chemical that comes from car exhaust and from nylon and polyester clothing. That explains why atopic dermatitis has been becoming more common, particularly since the 1970s, because the 1970s, car exhaust changed to start to have this TDI in it, and that was because they put catalytic converters on cars. Second, nylon and polyester became much more common in clothing, and residual TDI in nylon and polyester clothing is the other big driving factor for this acquired atopic dermatitis. And and I do want to be clear, it's not that that TDI doesn't affect kids. It does affect kids with inherited atopic dermatitis. So it takes those kids who already had it and makes them much worse. Whereas in adults, they never would have gotten it at all, except for this chronic environmental exposure to these chemicals, in particular the toluene disocyanate from car exhaust and clothing. It explains both why atopic dermatitis has been getting more common since the 1970s and why people who live in cities are more likely to get atopic dermatitis than people who live in rural areas. It is because cars and therefore car exhaust is more dense in cities compared to in rural areas.